near the oven. Also steel workers. Nowadays, the mortality from stones is very rare. So there is a balance in the body between urinary promoters and urinary inhibitors. So the most important promoters are calcium, oxalate, phosphate, ureate, cysteine. And this can result from absorption in the body or malsecretion of these solutes. The most important inhibitors are citrate, magnesium, pyrophosphate, uromodulin, and the most important one is citrate. So any imbalance in this equation can result in stones if the urinary promoters are more. And usually the stones result from something called Randall's black, which form the nidus for the stone. And the stone will form on top of this Randall's black, then it will break and it will be excreted in the collecting system. Stones, calcium oxalate, it's the most common, followed by uric acid stone, then strobite or infection stone, calcium phosphate, cysteine, xanthine, and drug-related stones. So we'll speak about each one of them in details. But first, we will have a look on the classification based on pathophysiology for the stones. So for calcium oxalate, it can result from hypercalciuria, and hypercalciuria can be subdivided into absorptive, resorptive, or hyperuricuric. Absorptive hypercalciuria, from the name, it indicates that there is more absorption of the calcium in the body, or there is impaired phosphorus absorption. For renal hypercalciuria, there is impaired renal calcium reabsorption. Resorptive hypercalciuria, it means there is more calcium in the blood coming from the bone, like in primary hyperparathyroidism. So these are the most important one that you need to know about. For resorptive hypercalciuria, the most common cause are hypercalcemia of malignancy. Anyone knows what's the pathophysiology of hypercalcemia in malignancy? How the calcium gets high in the blood in malignant patient?
Parathyroid.
Result of chemotherapy causing destruction of the cancerous cells?
No, there is a substance. There's a name of substance. It's actually parathyroid hormone related protein, PTHRP. And this substance, it acts like parathyroid hormone, and it moves calcium from the bone to the blood, and it's excreted from the tumor cells. What about sarcoidosis? What's the pathophysiology of hypercalciurium sarcoidosis? How the calcium gets high in the blood in sarcoidosis patient? Yes, so
Increasing the vitamin D activation.
exactly. There is an enzyme in the macrophage in the cells, in the granulomatous cells, that's called alpha hydroxylase enzyme that's convert vitamin D to the active vitamin D that can increase calcium reabsorption and can increase calcium in the blood. So what's the most common cause of hypercalcemia in outpatient setting? If you say a patient in the clinic and he has hypercalcemia, what's the most common?
Hyperparathyroidism.
Exactly. Primary hyperparathyroidism is the most common cause of hypercalcemia in outpatient setting. What about inpatient setting? Exactly.
Improper IV fluid.
Malignancy or cancer. Excellent. That's it. Okay. Sorry, I'm trying to go back to the presentation.
البرزنتيشن واضح عندي يا دكتور.
ايه بس I want to move the slide. I'm trying to press فيه السهم اللي تحت بس it's not moving.
يعلق بعض الأحيان، يبيلك تصبر
ايه
عليه شوي.
معلق. لا بس يبغالي ارجع. انا ابغى كانت عندي الويندو واضحة قبل. معليش. إيه معليش، السهم اللي تحت الكيرسر مو قاعد يتحرك، معلق.
جرب دكتور توقف العرض كاملا وتشغله من جديد.
لا خلاص، لا خلاص ضبط. لأن فيه كذا على اليمين بس مرة بطيء.
دكتور،
أيوة.
استفسار، انت قلت مالجنسي، بس ايش قصدك؟ مالجنسي ميتاستاسايز ولا اي مالجنسي؟
كيف؟ can you say it again؟
انت قلت الموست كومن اللي يرفع اللي هو نسيت وش هو بالضبط، اللي هو المالجنسي، فقلت
اللي هو
هل
الهايبر كالسيميان امبيشنت.
ايه انبيشن، هل هو مالجنسي ميتاستاسايز ولا مالجنسي وش بالضبط؟
لا اني
وش
مالجنسي، اني مالجنسي،
ممتاز.
اني كانسر. طيب الحين واضح عندكم سلايد رينال تيبولار اسيدوسيس؟
اي واضح.
Okay. طيب we'll speak about renal tubular acidosis. It's a very important topic, especially in nephrology when you take medicine. It's mostly a medical disease that's characterized by metabolic acidosis in the blood, and it's resulting from defect in the intercalated cell in the kidney. So there is a problem in hydrogen secretion and bicarbonate reabsorption. So if you have problem in hydrogen secretion in the urine will not be acidic. If you have bicarbonate reabsorption problem in the blood will be acidic. So the most common type and the type that's important to know for you, it's distal RTA type 1, because this is the type that's mostly associated with stones. And 70% of these patients, they have a stone formation. And the most common reason, as I mentioned, this is the intercalated cell that's coming slowly. Okay, so this is the intercalated cell. So usually there is an excretion of hydrogen ion to acidify the urine, and there is reabsorption of bicarbonate in the blood. So if there is a problem in this pump, so the hydrogen will not be excreted in the urine, it will cause alkaline urine. And if the bicarb is not absorbed in the blood, it will cause acidic blood. So just I want to go back to show you. Okay, so it's abnormality in the collecting duct, and the classic finding include hypokalemia, hyperchloremia, hypocitraturia, metabolic acidosis. Metabolic acidosis because bicarb is not reabsorbed. Hypocitraturia because if you are not secreting hydrogen in the urine, the citrate in the urine will be low. And the citrate, as I mentioned before, it's an important inhibitor. So you need citrate in the urine to inhibit stone formation. So if the citrate is low in the urine, you will have more risk for stone formation. Okay, so we'll start with the first stone type, which is calcium oxalate, and it's the most common. And as I mentioned earlier, it results from Randall's plaque. And Randall's plaque itself is a calcium phosphate. And calcium oxalate will be on top of it, and then calcium oxalate stone will break and it will be excreted in the urinary system. This is an example of Randall's plaque. This is a picture during ureteroscopy inside the kidney, and you can see this yellow spots, yellow whitish spots. These are Randall's plaque. And these Randall's plaques are the origin of urinary stones. So what are the most important risk factors for calcium oxalate? The most important one is dehydration. And as I mentioned earlier, during the summer, because of dehydration, there is more risk for stones. Also, hypercalciuria that can result from any reason, hyperparathyroidism or malignancy or any other reasons. Hyperoxaluria, which is more excreting more oxalate in the urine. Hypernatrituria, which is excreting more sodium in the urine. Hypositraturia, which is low citrate in the urine. So this is important to know. Citrate is very important inhibitor in the urine. So you need citrate in the urine. That's why I will talk in the medical or in the treatment part about the importance of giving the patient citrate or asking the patient to drink lemonade or orange juice because of it's rich in citrate, so it can prevent stone formation. The other type is uric acid stone. It's the second most common. It can affect, it comprise 7 to 10% of all urinary stones. And typically, it forms in acidic urine. So the urine pH, it can be acidic, which is less than 5.5. And if the urine is acidic, the patient has higher risk of forming uric acid stones. So the treatment for this type of stone, you have to keep the urine alkaline, meaning you have to keep the urine pH more than 6. And uric acid stone can result from gout or any disease that can cause hyperuricemia in the blood, like chemotherapy for lymphoma or leukemia, that can cause uric acid stone because it's producing more uric acid in the blood.
دكتور
Strovite or triple phosphate stone, or it's called infection stone. It's called so because of formation of this stone in the setting of urinary infection. And usually the most common infection are urease producing organism like Proteus, Klebsiella, Enterobacter, and Pseudomonas. You have to note that E. coli is not a urease producing organism. And one of the content of strovite stone is phosphate, and phosphate is less soluble at alkaline. So you have to make the patient more acidic. You have to acidify the urine to make this stone more soluble. And basically what the organism does, it produces urease, which confirmed the urea to ammonia. And ammonia is the reason for the urine to be alkaline in the setting of this stone. And usually they form a distinct shape, and it's called staghorn calculi. And you can see on the right-hand side, there are bilateral kidney stones form as a staghorn. So these are typical of strovite stone. The other type is calcium phosphate stone. And as I mentioned earlier, calcium phosphate stone, it's the Randall's plaque or the origin or the nidus of any stone, especially calcium oxalate stone. And usually it results from renal tubular acidosis, the one we mentioned before, primary hyperparathyroidism, medullary sponge kidney. All these diseases can predispose the patient to calcium phosphate stone. And usually it forms an alkaline pH. So if the pH in the urine is more than 7.2, it's a good medium for calcium phosphate stone to form. So if the patient has uric acid stone, and we mentioned that uric acid stone form in acidic urine. So to make uric acid stone more soluble, you have to alkalinize the urine. But if you alkalinize the urine too much, like more than 7.2, the patient can form another type of stone, which is calcium phosphate stone. So there is a balance when giving the patient alkalinization, and we will talk about that in medical treatment. The last type is cystine stone, and usually these stones are genetically formed because of abnormality in the amino acid, cysteine amino acid. And to get rid of this stone, you have to make the urine pH very alkaline, more than 9.6, which is not very practical in real life. So what the advice we give the patient is that they have to drink more water, and there are certain medications that can be given to cysteine that can be complexed with cysteine and can be excreted in the urine. The last but not the least is medication induced, and medication induced are two types. There is medications that form from the drug itself, and there are stones that provoked by the drug. So meaning if you take the stone and analyze it, it will be the medication itself. But the stones that provoked by the drugs is the drugs is causing a mechanism that produce either hypercalciuria or hyperuricisuria. So this is the list. Mainly the stones that's formed by the drug is HIV medication like indinavir, cold medication like ephedrine, silicate, antibiotic like trimethoprim. The drugs that can form or can be provoked by the medication is carbonic anhydrase inhibitor that's used in a patient with high blood pressure, topiramate, furosemide, which is used for patient also with hypertension, vitamins like vitamin C and D. Then what happens when the patient has obstruction? So when the patient has obstruction, you have to differentiate between unilateral and bilateral obstruction. So there is a difference between unilateral on the left side, bilateral or solitary kidney. What you have to know from this figure is that in unilateral obstruction, initially there will be vasodilatation, vasoconstriction, then vasodilatation in the kidney. The GFR will be maintained initially. But in bilateral obstruction, the GFR will decrease more rapidly and the effect will be faster compared to unilateral obstruction. And usually it takes the kidney 2 weeks with obstruction to be compromised. So the kidney can stand about 2 weeks of obstruction until it develops kidney failure. Okay, so now we'll move to clinical presentation. The most important one is pain. So most of the patients, they will come with colicky flank pain that can radiate to the groin or the scrotum. Sometimes they have nausea or vomiting. And the reason for that is because of hydronephrosis and capsular distension in the kidney. When the stone moves to the uretrovesical junction and it moves down, the pain will change. So the pain will not be in the back, it will be more in the front, and the patient will develop some irritative symptoms in the urine like urgency, frequency, and dysuria. 55% of the patient, they have family history of stones. So it's important to ask in the history about family history, if anyone in the family has any stone in the past. On physical examination, the patient, of course, will be distressed, will not be lying comfortably in the bed. The patient will constantly moving around to find a comfortable position. So this to make it different from the patient with peritonitis. The patient with peritonitis or acute abdomen, they will be still in the bed. They will not move. They will try to avoid any movement. So that's the difference between renal colic and acute abdomen. Also in examination, you can tap the back of the patient to elicit costovertebral angle tenderness. Some patients, they have gross or microscopic hematuria associated with flank pain. So this table is important to know. Any patient coming with acute renal colic or pain in the back you have to know these differential diagnoses. It can be renal or ureteric stone. It can be hydronephrosis. It can be pyelonephritis or bacterial cystitis, lobar pneumonia, rib fracture, or any condition that can cause acute abdomen, either in the bowel or pancreas. Also, gynecological problems, ectopic pregnancy or ovarian torsion or rupture. Also, herpes zoster. If the patient has herpes zoster, they can have pain. Unless you undress them and examine their skin, you wouldn't know. So it's important to undress the patient and check his skin to make sure the patient doesn't have herpes zoster. Also, finally, it can be referred pain from orchitis. So for diagnostic evaluation, imaging is the cornerstone for diagnosing any calculi. So this is an X-ray, a KUB, and you can notice here there are hyperdensities in the pelvis. Usually the stones are not very nice and round like this. So these are most likely pelvic phlebolith, which is calcification of the pelvic vessels. So to know if it's a stone or not in the urinary tract, you have to know the anatomy. And usually this is the anatomy of the kidney. You can see the kidney shadow here. And also you can see the ureter. There is proximal, mid, and distal ureter. And usually the uretrovesical junction, it opposite the ischial tuberosity. Do you see my mouse, the cursor? I'm moving or not?
بوينتر مو واضح دكتور.
لا دكتور،
طيب.
بلاك بورد كله ما يوضح البوينتر الحين.
يعني لازم اسوي خط ها؟
اي الخط هو اللي واحد.
الخط او القلم دكتور؟
اي طيب باش احاول. ايوه هنا واضح؟
ايه اللي تحت يمين واضح.
ايه هذه الاسكيال tuberosity. طبعا this ischial tuberosity opposite the uretrovesical junction. So to know if what you see, the calcification you see in the X-ray is a stone or not, you have to see the cause of the ureter. So here you can see that this is the ischial tuberosity, and usually the uretrovesical junction is opposite the ischial tuberosity. Okay, then we move to so what should we use to diagnose stones? Usually we start with KUB, X-ray, simple X-ray. Ultrasound also can be done in certain patients like a young patient, young female patient, or a pregnant patient. But if the diagnosis is not clear, usually we do a CT scan without contrast. And this is an example of a CT scan. And you can see on the right kidney, there is, as you see in the pointer and the arrow, that there is a stone in the kidney. Also, this is another CT scan and an X-ray at the bottom. And you can see here there is a collection of multiple stones, and this patient has severe calcification of the kidney. And this condition, we call it nephrocalcinosis. Nephrocalcinosis because the kidney mostly calcified because of the stones. So as I mentioned, usually we start with the X-ray, ultrasound, or CT scan. Ultrasound, it's useful in pregnant women because in pregnant women, you can't do X-ray and you can't do CT scan, but you can do ultrasound, and there are certain maneuver in ultrasound that can indicate if the pregnant woman has obstruction or not. Because in pregnant woman, normally there is hydronephrosis. And to know if this hydronephrosis is physiologic from pregnancy or from obstruction by the stone, you have to do resistive index, which is you are seeing the flow, the blood flow in the urine and in the ureter, and there are certain calculation. You don't have to know the details, but just to know that there is some maneuver we can do an ultrasound to know if there is obstruction or not. Okay. Contrast CT, usually, as I mentioned, we do CT without contrast. But when do we use contrast? We use contrast because there are certain stones that's formed by HIV medication like Indinavir. And these stones, even with the CT scan, you can't see them. So you have to use contrast, and you see them as a filling defect with contrast. So basically, when you see the patient with urinary stone, you have to assess, does this patient need urgent intervention or not? So what are the indications for urgent intervention? Basically, if there is obstruction with infection, so if the patient has fever, you have to intervene urgently. And also if there is increase in creatinine, or you think there is impending renal failure for the patient. Also, if the patient has pain that you are giving medication but it's not working. Also, if the patient has intractable nausea or vomiting. Also, if the patient prefer the intervention, like if you usually when you see the patient, you present to him the options. You tell him either I can give you medication or we can do intervention, and the patient will choose. So this is a picture during cystoscopy, and this is the bladder. This is the ureteric orifice, and as you can see here, there is pus coming from the ureteric orifice. And when you see this pus coming from the ureteric orifice, it means there is a severe infection. So you don't manipulate the stone or fragment it or do anything. You just put a double J or a stent, and you come out, and that's it. I put here a nice video, but unfortunately, it seems that it's not compatible with the Blackboard. ما في طريقة نشغل الفيديو صح؟
لو سويت دكتور شير سكرين يشتغل.
شير سكرين المشكلة. طيب شير سكرين. طيب بحاول أشوف الفيديو. أيوه هذا هو شكله. شايفين الفيديو؟
اي واضح.
واضح.
واضح يا دكتور.
طيب هذا patient, a real patient with a stone in the bladder. And I'm fragmenting the stone with the laser. And you can see the stone has an outer side core and an inner core. This is the prostate. So the patient usually, if they have bladder stone, it's because of enlarged prostate. So if the patient has enlarged prostate, it caused urine stasis, and the patient will form more stones in the bladder. So usually this is how the stone look like. There is sometimes there is an outer side core or color different from the inside core. And these stone can be either calcium oxalate or uric acid stones. And this stone measures around 2 to 3 centimeter. So if the patient has a stone in the bladder, it means he has obstruction in the prostate. So you have to also remove the prostate. Okay, good. طيب الحين كيف ارجع لل presentation؟
نفسه دكتور اللي هو فنفسه لو تسوي
إيه.
في فوق يمين دكتور مربع، تقدر توقف العرض وتبدأ.
يمين دكتور،
الجهة
يمين
الثانية
المربع
دكتور.
اليمين اللي فوق
يمين.
الشاشة. فوق
share now.
إيه لا، عشان طفي الشير سكرين فوق.
إيه فوق وين؟ هذا
جنب ايوه هذا.
ايوه صح ممتاز. طيب نرجع للبرزنتيشن. طيب okay. Uh, so as I mentioned, if the patient is unstable or septic, the patient has fever, or the patient has pus in the urine, you don't manipulate the stone. You just drain the kidney by nephrostomy tube or by the double J. And sometimes the signs of infection, as I mentioned, can be fever or high white cell count. Also, they can have pus cells or bacteria in the urine analysis. But what if the patient has pus cell and bacteria in the urine but no fever? Would you consider it infection? شباب
اتوقع ايه دكتور؟
طيب would you treat him as a patient with fever? Like, does he need urgent intervention or not? Exactly, it's not urgent. لأن زي ما انتم عارفين there are steps or stages for sepsis. There is SIRS, which is systemic inflammatory response system. And there is sepsis. So if the patient has pus cell in the urine analysis or bacteria, and he doesn't have fever or chills, it means he's not bacteremic yet or he's not septic yet. So you can wait. Okay, that's why always we say you don't treat the labs, you treat the patient. So you have to look to the patient symptoms, not only the labs. Okay, so here is a summary of the management for renal stones. So you start with a CT scan, and you have to decide if there is urgent intervention or not. So this is the cornerstone. Is this patient need urgent intervention or not? What are the indications for urgent intervention? It's obstructed, infected system, or increase in creatinine. There is intractable pain, nausea, vomiting, or patient preference. So if you triage the patient and you feel that there is nothing urgent, then you can move to the non-urgent pathway. الارو واضح صح اللي انا قاعد اكتب؟
اي واضح
إيه نعم.
دكتور.
ايه.
واضح
You move to the non-urgent pathway. طبعا ال non-urgent pathway you discuss with the patient, depend على stone location and depend على stone size. If the stone is small and it's distal ureter, you can assure the patient and tell him, we will observe you. If the stone is big or in higher location, like in the kidney and causing any issues, you can do intervention. And the intervention طبعا depends on the type of the stone. Is it uric acid stone or non-uric acid stone? Uric acid stone, you have, as I mentioned before, uric acid usually form in acidic urine. So the pH of the urine will be 5.5. So what you have to do is alkalinize the urine by giving medication with citrate that can make the urine more alkaline, so the uric acid stone will dissolve. Non-uric acid stone, also you can give some medication to try to treat the stone, but you have to look also at the pH. If the pH acidic, you have to alkalinize the urine, and you can give medication to try to move the stone down. Okay, that's it. So we go to the next slide. As I mentioned, if there is a high-grade obstruction, like moderate or severe hydronephrosis, or if there is a solitary kidney, or if there's an increase in creatinine, you have to do urgent intervention for the patient. So we'll speak now about the management. So for pain, you have to manage the pain with non-steroidal anti-inflammatory drugs. But you have to be careful. What are the contraindications for non-steroidal anti-inflammatory drugs?
acute kidney injury,
Okay, so you have to look at the creatinine.
أزمة.
Okay. Yeah, viral infection maybe. Yeah, okay. What else? Gastric ulcer. Gastric ulcer, exactly, peptic ulcer, or if the patient has risk of bleeding, or if you are taking the patient to surgery, and as mentioned, AC inhibitor, renal artery stenosis. That's right. Good. Okay. Then we move to something called expectant management, which means I will show you a table. So from this table, you would see that if the stone size is less than 3 millimeter or 2 millimeter, it requires a few days to pass, 8 to 12 days. And the likelihood of needing an intervention, it's very low. But if the stone is more than 4 millimeter or 5 millimeter, the number of days required to be passed, it's like more than 20 days, and the likelihood of needing intervention is high. So expectant management is when the patient has small stone in a favorable location like distal ureter, you can watch the patient by asking the patient to drink water. You can give him something to alkalinize the urine, and you can just monitor the patient. And most likely for these 4 stones less than 5 millimeter, because these stones, as I mentioned, there is a likelihood the chance of passing spontaneously. So 2/3 of ureteral stone, they will pass spontaneously within 4 weeks. So that's why we watch the patient usually between 4 to 6 weeks. And then we can give something called medical expulsive therapy. So medical expulsive therapy, which is calcium channel blockers or alpha blockers or non-steroidal. But usually we use alpha blocker. And the most common example is, as you know, tamsulosin. You know tamsulosin, right? You know tamsulosin?
لا دكتور.
Huh?
لا ما أخذنا.
It's
سلوسين
it's alpha blocker. It's alpha blocker, okay? And it's usually we use it for patient with BPH. أخذتوا محاضرة البي بي اتش ولا لسه؟
لا.
ايوه. ايه طبعا راح تاخذون محاضرة البي بي اتش. هذا alpha blocker used in BPH patient to relax the bladder neck so the patient can void better, and also it's used in the stones to increase the likelihood of passage of the stone. Okay, so when the patient has a stone, you have to tell him that he has to watch for the stone when he passes so he can catch it. Why?
To see what's the kind of stone and to see
Exactly.
if there is any family-related
Exactly, excellent. Yes, to see what kind of stone, what type of stone, so you can prevent it or you can give medication to prevent it in the future. And also you can do metabolic analysis of the stone. So if it's calcium oxalate, you know the patient has a problem in the calcium. If uric acid, you know the patient has a problem in the uric acid. So you have to test the patient for uric acid in the blood, uric acid in the urine, and that's it. So we mentioned that. Okay, so what are the options? The options are medication, oral stone dissolution therapy, and as I mentioned, it can be to alkalinize the urine because uric acid forms in acidic urine. So you have to alkalinize the urine with something like citrate. Also shockwave, which is a machine from outside that can fragment the stone. Ureteroscopy, which is a scope that you go inside the ureter. PCNL, which you go on the side of the skin to fragment the stone. Then the last option is open or laparoscopic lithotomy. So these are the options. This is shockwave, which is basically doing a shockwave from outside to fragment the stone, and it's usually done under local anesthesia. This is ureteroscopy, which is you go with the scope through the natural orifice, then through the ureter and into the kidney to fragment the stone. This is BCNL, which is percutaneous nephrolithotomy, and you go through the skin, and it's a more advanced procedure. So, as I mentioned before, urinary alkalinization is an important step in treating uric acid stone, because uric acid stone form in acidic urine, so you have to alkalinize the urine with citrate or sodium bicarbonate. So sodium citrate, because as I told you, citrate is an inhibitor, and it also will increase the pH of the urine to make it alkaline. Sodium bicarbonate will make the urine alkaline too. So what's my target? If I give the patient something to alkalinize the urine, what's my target? I will follow the urine analysis with the pH.
I
What?
thought this was a question.
No, yeah, I'm just, no, so it's 6.5. So 6.5 is the target for you when you treat a patient with acidic urine. So you have to maintain the pH around 6.5. Because as I told you before, if you alkalinize the urine too much, more than 7, you can predispose the patient to another type of stone, which is calcium phosphate stone. Usually we do shock wave for the stones that less than 3 centimeter. If the stone is more than 3 centimeter, then you can do BCNL or ureteroscopy. And mostly proximal stone, like in the kidney or in the upper ureter, it's treated by shock wave. And stone that in the distal ureter, usually we treat them with ureteroscopy. So the patient has a stone and you want to do prophylaxis so he doesn't develop another attack of stones in the future. So what you have to do is you have to do a metabolic workup to know what's the reason for the patient that he is forming stones. What's the metabolic or the endocrinologic abnormality that's predisposing the patient to stone? Because there is a pathophysiology behind the stone. So you have to find it and you have to treat the patient. And mostly in this table, it's showing you, you don't have to memorize this table, but you have to know what are the investigation we do to know what's the reason or what's the pathophysiology of the stone. So first, I have to know the volume of the urine to know if the patient is drinking enough water or not. I have to know the pH, to know if the pH acidic or alkaline. Then I have to measure the solutes or these contents in the urine to know if something increased like calcium or oxalate, you give medication targeting these substances. This is for urine over 24 hours. Then in the serum, you have to measure certain substances like calcium, phosphorus, uric acid, creatinine. Also, if the calcium is high, you have to measure parathyroid hormone to see if the patient has hyperparathyroidism. And as we mentioned and discussed before, you have to know the stone composition if the patient pass it and you send it for analysis. So usually from the metabolic workup, what are the most common metabolic abnormalities we can find? Usually either low urine volume, so you ask the patient to drink more water, hypercalciuria, which is increased calcium in the urine, or increased oxalate, or low citrate, or high uric acid. Also, one of the strategies to prevent recurrence of the stones is to do lifestyle modification for the patient by asking him to drink a lot of water. Also, to ask him to limit intake of certain food that can predispose him to stones, like tea, black tea, chocolate, spinach, beets, nuts, pepper. All these food can predispose the patient to forming a stone because it contains lots of oxalate. This one you don't have to know, just for your interest, that there are certain shapes for the stone when we examine them under the microscopy. And this table summarizes the stones. So for calcium oxalate, as we mentioned, it's the most common stone, and the shape is envelope, and it's radio opaque. What does it mean, radio opaque?
It shows on X-ray.
Excellent. Excellent. On X-ray, you will see it as a density. And as I discussed with one of the groups in the bedside teaching yesterday, I showed them an X-ray in a patient with kidney stone. So when you see a density on the X-ray, you don't say a stone because you don't know for sure it's a stone or a fracture or a density. So you just say it's a density in the area of the kidney or a density in the area of the ureter. I have to confirm it with a CT scan. Then the other type is calcium phosphate. It's radio opaque also, and it can be it can occur in this condition: primary hyperparathyroidism, distal RTA. Uric acid stone, it's a diamond shape and it's radiolucent. What does it mean?
It does not show.
Exactly.
On X-ray.
Exactly. As I discussed with the bedside teaching yesterday, you can't see it in the X-ray, but you can see it in the CT scan. And to know if the stone is radio opaque or radiolucent, you have to measure something called Hounsfield unit. On the CT scan, you measure the Hounsfield unit, which means the hardness of the stone. If the stone is more than 500 Hounsfield unit, it means you can see it in the X-ray and you can do shockwave for it. Because if you can't see it in the X-ray, how can you do a shockwave for it? Strobite stone, it's radio opaque. Cystine stone, it's radiolucent. Finally, we'll speak about stones in pregnancy. So diagnosis can be difficult, as we mentioned, because the pregnant woman will come with pain. You don't know, is it appendicitis, diverticulitis, or related to the placenta. And the pathophysiology behind stones in pregnancy, it's because of the placenta producing 125 vitamin D, that increase intestinal calcium absorption. So as I mentioned before, we have to use ultrasound and we have to avoid X-ray or CT scan. So in summary, urinary stones present with renal colic and hematuria. Some patients, they can have nausea or vomiting. Hematuria can be gross or microscopic in 15% of the patient. Usually, or the single best initial test is CT scan. So it's different if I ask you in the MCQ, what's your next step or what's the single best next step? If I say, what's your initial step? You can say X-ray. But if I ask you, what's the best or what's the most accurate? It's CT scan. So you should assess the patient first, as I mentioned, if he needs urgent intervention or not. And also you have to do metabolic analysis to know the reason for the stone formation. Okay, that's it. Thank you so much for listening. Any questions?
دكتور، بالنسبة للانفستيجيشن دكتور، نبدأ بالاكس راي ثم سي تي.
صح، بس على حسب السؤال. إذا قال لك what's your initial X-ray, but what's the best initial or what's the best next step CT scan.
ممتاز. والبريجننس التراساوند على طول.
Exactly.
ممتاز.
في نقطة دكتور إذا ممكن.
تفضل.
في على هذه النقطة الإكس راي والسي تي، إذا قال what's your next أو what's your initial management أو initial diagnostic method، وحط لي كل خيارين سي تي وإكس راي، ما قال لي بس، قال لي what's your next، هل أختار أيهن؟
إكس راي.
تمام.
إكس راي. Usually you start with simple.
واضح. من ناحية دكتور renal tubular acidosis.
ايوه
تقدر تعيد شرح النقطة حقتها؟
نفس الديزيز.
ايه، ولا هو اصلا مو تبع السيرجيكال ديبارتمنت عموما؟
الا مهم. انا قلت لكم الرينال تيبولار اسيدوسيس في 3 انواع. التايب 1 is the most important لانه هو اللي ريليتد للستون فورميشن، ويوجوالي البروبلم تكون بالانتركاليتد سيل. هذه الانتركاليتد سيل الهيدروجين is excreted باليورين نورمالي عشان يخلي اليورين اسيدك، والباي كارب ريابزوربد بالبلد عشان يخلي البلد الكلاين. بس بالتايب 1 يصير في مشكله بالانتركاليتد سيل، فالهيدروجين نوت اكسكريتد فيصير عند البيشنت الكلاين يورين، والباي كارب از نوت ابزوربد فيصير عند البيشنت اسيدك بلد، فيصير عنده ميتابوليك اسيدوسيس.
ايه
وطبعا
واضح.
يصير عنده لو ستريت، واللو ستريت هذا يسبب البيشنت بريدسبوز للستونز.
ايه واضح دكتور. الاذر تايبس ما لها علاقة بالستون فورميشن لكنها
لا
تسبب
not
نفس
important. لا not important.
ايه تمام.
اي سؤال ثاني؟ طيب if no more questions we'll conclude. Thank you so much. الله يعطيكم العافية جميعا وبالتوفيق إن شاء الله.